I'm Jeff Marshall. I'm the president of SCAI, and I'm honored today to be with Dr. Ajay Kirtane from Columbia Presbyterian Medical Center, an interventional cardiologist there, someone who's real familiar with randomized clinical trials, and we're going to have a little discussion about FAME2. Ajay, can you talk a little bit about the preliminary action that the DSMB had to do for FAME2?
Sure. I think just as a background for the trial, basically the trial was one that randomized people that actually had true ischemia as documented by FFR and FFR less than 0.8. And those people were in the lab, and with an FFR less than 0.8, they were randomized to either best medical therapy or medical therapy plus PCI, which in this case included the preponderance of drug-eluting stents, second generation in particular. And basically what happened is that the primary endpoint was supposed to be a composite of death, MI, and unplanned hospitalization leading to urgent revascularization. And at an interim look early on, the DSMB noted that there was an excess of unplanned hospitalization leading to urgent revascularization among patients randomized to medical therapy alone. And because the difference was so striking, they elected to stop the trial, and that happened several months ago.
Yeah, it was pretty shocking they stopped it early, I thought. You know, there's been a lot of the pundits, a lot of the editorials have actually kind of compared this somewhat to Courage. And I wonder what your thoughts might be 5 years from now. What do you think would be really more enduring? Are results from Courage or these really fascinating results from FAME2 with documented ischemia?
You know, actually, I find that they both are pretty consistent, to be honest with you, and so I think they'll both endure. The differences predominantly relate to the fact that these are people we know that all have ischemia as documented with an FFR. They were treated with more modern therapies. Courage had a lot of bare metal stent use for the most part, very little drug-eluting stent use. So this reflects more modern practice, but in 5 years we may be doing different things. The key messages from both of them, though, are that, first of all, there's no excess risk associated with stenting patients up front. There's no MI disadvantage in either FAME2 or Courage. And in fact, if you look at both studies, patients felt better when you treated them with upfront angioplasty and stenting. And in FAME2, perhaps because the patients are even more enriched by the fact that they have ischemia, they were able to prevent this event of these unplanned hospitalizations, essentially presentations of acute coronary syndromes.
This year, trying to focus on quality of life of our patients. A lot of previous discussion has really been on hard endpoints like death and MI, which in reality with bypass surgery and angioplasty, there are very few scenarios which we alter that. So thinking about quality of life, could you make any comments about the quality of life for our patients in FAME2?
Definitely. First, though, the issue of death or MI, I think the problem that we have is we don't usually randomize the patients that are going to have death or MI benefits. So we don't randomize patients with a 99% left main to revascularization versus medical therapy because we know that the revascularization helps. And so I think that the focus only on death or MI is probably a little short-sighted unless we randomize those patients, which ischemia is going to try to do. As far as quality of life, though, FAME2 clearly shows that patients felt better who had upfront angioplasty than those who were treated with the best medical therapy. And in addition to that, they were less frequently treated with calcium channel blockers and other anti-anginal medications. So, and this is within 6 months. So clearly, this is more data supporting the benefits of PCI for quality of life related outcomes. And you could even argue that coming back to the hospital after having an initial angiogram for an unstable coronary syndrome, that alone affects somebody's quality of life, maybe even more than a minor troponin leak might post PCI. So from a quality of life standpoint, I think these data are very reaffirming. You've been a real driver of the focus of SCAI in this regard, but ultimately what we're trying to do for our patients is improve their outcomes. And the outcomes are not measured by patients in terms of death or MI percentages. They're measured in terms of how they feel.
Absolutely. Well, Ajay, I really appreciate it. Thanks very much. And this is Jeff Marshall with Dr. Ajay Kirtane from Columbia. Thanks very much.